We have another panel. I believe right now we're going to welcome, the next topic is exploring current treatment options. Dr. Payam Mahasal from Johns Hopkins, Dr. Sheila Riazi from University of Toronto. All right. And Dr. Vermans from Radboud University Medical Center. Each is a leading clinician and member of the RY1 Foundation Scientific Advisory Board with extensive experience in neuromuscular disorder and clinical research for rare muscle diseases. We are honored to have them on the stage to share their insights. Here they are. Thank you. All right, I want to advance. All right, so I just want to sort of set the stage here, and these are all stolen from Dr. Dirksen. Just to make sure we're all on the same page here, what we're talking about is, again, skeletal muscle, voluntary muscle. These are the muscles that we control. We saw some of these graphics earlier, or some variant of it, where we see that within these muscle fibers, we have this very important component called the transverse tubule, or the T-tubule. Let's see if I have a pointer here. Yeah. And so what we're talking about here is the ryanodine receptor, which is right here. This is this calcium channel that is embedded in the wall of what's called the sarcoplasmic reticulum. This is just, think of this as kind of like, again, the tank on the toilet bowl. And these green dots are the calcium ions. And so any abnormality, the ryanodine receptor, which would be due presumably to a mutation or variant on the RY1 gene. So any abnormality at this level right here is going to cause a problem. So whether it's not enough calcium flowing through the ryanodine receptor, too much calcium flowing through the ryanodine receptor, or in the severe cases of myopathy, simply not enough ryanodine receptor, it's going to cause a problem. And so when we talk about potential treatments, what's currently out there, we're talking about drugs that would primarily act at the level of the ryanodine receptor. There are some things that maybe act at downstream sequela of abnormal function of the ryanodine receptor, but this is, just to put this into context, this is what we're talking about right here. Again, the toilet bowl analogy that we've talked about, which I think is just a great analogy. What we're talking about is, can I go back? Yeah. The flapper, the ryanodine receptor, and how can we use currently available drugs to make this flapper more functional, to get a better flush, if you will. All right. So this is a schematic that was in an article by several people, primarily at NIH, Joshua Todd and Toke Slawal, and I think it's a great schematic because, again, what we're talking about is this ryanodine receptor, again, embedded in the wall of the sarcoplasmic reticulum, and it illustrates the various drugs that are out there that have been tested either in a clinical setting or in a lab setting, and how they may be used to benefit patients. And so I just want to talk and pose some questions to our panel. Things that we see here are things like dantrolene, Icar, Rycals, 4-PBA, salbutamol or albuterol, and NAC. Some of these things have come up over the course of this meeting, and I think a lot of people have questions. I think I'll start with salbutamol or albuterol because I think that is something that, at least anecdotally and on social media, I hear a lot of people talking about. If people are willing, I think we did this the other day, can people raise their hands if they're using salbutamol or albuterol? So a fair number of people are using it, and I guess a question for the panel would be, can one of you kind of talk about the potential mechanism of action? Albuterol, Dr. Dirksen commented on this as well, but the arrow here is pointing to something called SERCA. And SERCA is not something we've really talked a lot about in this meeting, but can one of you be willing to talk about albuterol and maybe what you've seen in your clinical practice?
So albuterol is or salbutamol, they're beta adrenergic antagonists. And but anyway, so they're a class of medications that were developed really to treat asthma originally, and they do work really well as inhalers, and sometimes taken orally. There's a large class of them. But they do have these additional effects. And albuterol, which is the one available in the US and I know more about, has long been known to have anabolic effects, for example. So it was used as a drug to put muscle on cattle in Spain. And actually, when people ate the liver of those cows, they got all shaky because they got toxic from the albuterol that was in there. It has a lot of effects in muscle, not just in one. So it's really hard to pinpoint where. We do know it has an effect in the neuromuscular junction where the nerve and muscle communicate with each other. It has potentially an effect on SERCO, as it's pointed out here, and probably other effects that are not in the figure. But it seems like it would have a potential positive effect. So in these cases, it's best to assess the effect in patients just to see if it helps them. So there is an ongoing clinical trial of salbutamol in Europe for congenital myopathies, and that includes RYR1 patients in Sweden. And that trial, I think, has concluded, but the results haven't been made available yet. So we're excited to see what that showed. And we'll have essentially the gold standard kind of data from a clinical trial to be able to better say whether that's going to help patients or not. That will come soon. But in the meantime, I think it's reasonable to try albuterol in the right patient in consultation with the doctors to make sure it's not causing additional side effects, and then having a monitoring plan to see if it improves things for an individual. And I'll stop there and hand it off to Nicole.
We actually have two microphones here. So before you hand it off, and I do want to hear from Dr. Bermans, Dr. Mahasel, can you kind of briefly comment on your practice and how often are you prescribing it, and what clinical scenario are you prescribing in? And again, we're waiting for that gold standard data, but just anecdotally, what your perception is about the efficacy and safety of albuterol.
So I offer it to some patients with neuromuscular diseases that are more clearly shown to benefit from it, in almost all of them. So one example would be a congenital myasthenic syndrome patient with DOX7 mutations. There's a lot of good data that it helps those individuals, and I have one patient who essentially took that and was able to walk.
So Mike wants to know what it is.
Yeah, you're using these words I don't understand.
Yeah, so anyway, so that's a genetic muscle disease that affects the communication between the nerve and muscle, right? So, and for that disease, it works really well. For RYR1 patients that I see, it's a sort of an individual discussion. I don't think it's been shown or there's any rationale to think that it's going to be helpful for the malignant hyperthermia related symptoms, so the cramps, sort of the myalgia and all that. But for weakness, it might be useful. So I do sort of discuss it on a case-by-case basis, and based on the other comorbidities that the individuals have, I would offer it. Sometimes the patients ask me about it, and then that sort of makes me feel better about offering it, because if you're offering a drug that's not approved, it's kind of a gray zone, right? And so anyway, so that's sort of my practice. So it's very individualized, not consistent, and I don't prescribe it often for RYR1 so far.
Okay, Dr. Bermans.
I think I'm quite much alike of my practice. I do discuss it more often, but always with the disclaimer that it's not approved for this group of conditions, and not only in RYR1 related myopathies, but also in other congenital myopathies. And when people want to try it, we have two things to discuss. First, we have to ask the insurance company whether they want to cover for it, because it's not registered for it and has to be imported in the Netherlands as tablets at least. And two, how we're going to assess whether whether there's an effect. So I discuss with each individual patient, Are you followed up by a physical therapist? Can we ask a physical therapist to do a manual muscle strength test and an endurance test before you start and after a month and after 2 months? So there are some objective measures in addition to what the patient experienced him or herself in order to make the decision whether it works for this person, this individual.
Okay, great. I'm just curious, if, for the people who said they are taking out salbutamol, recognizing this is all anecdotal, but generally, do people feel that it's helping? Marcy, you want to comment on this?
Can you hear me?
Yep.
Oh, there you go. Yeah, actually, I can explain kind of where we are and also have a question about it. So I would say in elementary school, maybe when my son was about 8, he started getting really tired, like he physically couldn't make it through the day. So his neuromuscular doctor prescribed oral albuterol. So we started taking it lower doses, and obviously we did EKG, and we did what you said, where we worked with his PT and did different testing with him. I think we were doing, what my son called the 6-mile walk, 6-minute walk, and things like that, which he does with assistants. And what was interesting, I don't think it wasn't a strength improvement, but it was an endurance improvement. Like, he could literally make it through the day. And to this day, he's on 4 milligrams 3 times a day. And it's like, I just call it his endurance medication. And we found it to be highly helpful for him. He's had 0 side effects from it. We knew from a very young age that he wasn't susceptible to issues with albuterol because he used a nebulizer when he was first diagnosed with reactive airway, and he never had any reactions to using the inhaled albuterol. So switching to the oral, it didn't seem to bother him, didn't keep him awake or cause any issues. So it literally helped him immediately. So, and actually my question about that would then be, is the fact that it's become this endurance drug or whatever it's doing for him, he has a blocked calcium channel, right? What is it doing something on a muscular level? What could it be doing? And based on your knowledge of what it's doing, can we build on that and do something with medications to a stronger effect? I can't say the word. Efficacy. Thank you.
We understand.
Thank you.
Fine.
Sure. I mean, it's a tough question because it's one of those medications. A lot of medications like albuterol, which we call small molecules, don't just do one thing, and it's going to be very challenging to know which effect is doing what's giving the benefit. It's not impossible, but it needs to be really rigorously studied. I do want to also mention that the effect of it is short-lived, right? So you have to take the medication every 2 hours, right? So it's because it sort of goes out of your system within that timeline, and so improving that also would potentially be helpful in terms of convenience. So there's a lot that we need to learn, but if it clearly works, and especially the clinical trial is going to be really helpful once the data is out. If it shows that then that there's enough rationale to really study that in depth to see which effect is providing an improvement.
And I think in children, but also in adults, if endurance improves, it offers opportunities for training, and that can then subsequently give a positive feed forward and also maybe increase in strength because training becomes more possible and feasible for a child.
Great.
Thank you.
Was there another question? Oh, Mother. Don't
So,
fall.
wait a
Don't
minute.
fall.
No. With albuterol, has the manufacturer of this drug, are they at all interested in seeing if it would be helpful for people with a muscle disease?
So this has long been generic. Albuterol also doesn't really have a lot of financial benefit for the company to fund the clinical trial. So it would have to be done in the academic realm or investigator-initiated realm.
Thank you.
And that is what is currently happening in Sweden. And we had a similar case with the drug for myotonia. It's another neuromuscular feature. It was a drug which already existed for a long time, and we showed that it had a very good effect against myotonia. And then there was this company who bought the patent and invented it at the market for a rare drug for a very high price. But then we had a big argument in my country at least, and they were removed from the Dutch market, this company, and now it's available again, produced by the academic pharmacy for a normal price.
Great. Oh, question over here. Yeah.
So our son was on albuterol for a few months for the same reason, to see if it would help his stamina or help him fatigue less. But he ended up he already had some GI issues before that, but it ended up causing such a horrible constipation episode that we ended up in the hospital for several days with him. And it turned out he had severely low potassium levels. And in the hospital, we were told that low potassium is a side effect of albuterol, as well as it can dry out your system, which he was already struggling with constipation. But then our neuromuscular specialist was like, no, none of what you experienced was from the albuterol. So we chose just to stop it because it wasn't worth it. But I'm just wondering if those issues have come up for other people, low potassium, or do you need to like increase your fluid intake with that, or what your thoughts are?
So we don't have much experience with albuterol, but my partner at RMH Center, he has been giving to patients with fatigue with no response, to be honest, and some of them they're taking at 6 times a day, as you mentioned. But these side effects that you mentioned, they all make sense because it's a sympathomimetic. And it can cause constipation, and it drives potassium into the cell, which means you get low potassium in the blood. So these are all the effect of sympathomimetic, unfortunately.
Interesting. Very interesting. All right. Any other questions on albuterol? Oh, Cici.
Yeah.
Orlando from Brazil. Welcome.
Okay, I have a very good experience with me. About 1 year, almost 1 year and a half ago, I was going downwards. Like I was having problems rolling on the bed, difficulties in walking, a lot of pain on my back, ribs, legs, all over. And I got in touch with Dr. Nico, and because I heard about Dentrolin. And I asked about Dentrolin, and said, no, maybe it's not good for you because you can get too much relaxed, and maybe it's no good for you. Maybe you should try salbutamol. And I started to take salbutamol. It's something like miracle. I would say that a month after taking my physiotherapists that worked with me, they got amazed because I doubled my walking distance 400 times. If I could walk 1, I could walk 4 more times. I doubled the weight I lift. I used to do Pilates also. Pilates use strings. They double the strings I used to use. So that's the thing, and I'm still using the salbutamol.
Well, thank you for sharing that, but 2 comments, Orlando. Of course, I said you could consider it and talk about it with a clinician in your country, because that's what I was just discussing. I cannot give personalized medical advice, and I always want people to go to their own doctor, because if something is wrong, I cannot come and see you. And the other thing is not only the salbutamol or albuterol, but it's also your great ambition and dedication to live a healthy lifestyle and train. So it's the combination. I think it's definitely not only the pill which had this great effect.
Yeah, that's what I noticed. This thing made me feel better, so I could improve on the physiotherapy also, exercise.
Yeah. Orlando's a great ambassador for RY1 and potential therapies throughout really all of South America. He has a following in Brazil and very active on social media. So Orlando, thank you for everything you do. Really appreciate it.
And his own website in Spanish for all the Spanish people.
Yeah, right. Well, Portuguese.
Sorry.
Yes.
Stupid.
No, it's okay. No. So Orlando mentioned dantrolene. Dr. Riazio, can you comment on the role of dantrolene? And just to I'll sort of set the stage. For people who aren't aware, dantrolene is the antidote for a malignant hyperthermia reaction, an acute reaction from anesthesia. But there is an oral form that people could take electively, voluntarily, not in those sort of emergent situations. Can you talk about sort of generally what is the indication or what's an appropriate use for oral dantrolene?
Sure. So oral dantrolene was approved back in, I think, early 70s for cerebral palsy and all the spastic diseases too, because it's a muscle relaxant. And off-label use of that would be for patients with MH susceptibility and some of specific RYR1 patients to relieve their musculoskeletal or non-specific musculoskeletal symptoms. And we have been using at our center for a very long time, and right now we have about probably 300 plus patients on it. We published some of our retrospective data, and Nicole actually helped us to write it up. Thank you. I mean, our experience had been very good. We had 87% success. We had patients, so we basically offered to the patients with top probably 3 or 4 symptoms, which are like cramps and twitches, muscle pain, heat sensitivity, as well as fatigue. Not fatigability, fatigue, just the... some of the patients, unfortunately, either didn't tolerate because of the side effect, because muscle weakness is the major side effect with dantrolene. Now we try to get away with, adjusting the dose, or when we are giving it, we give it start at least giving it at night, so that by the time you wake up in the morning, you have less side effect. But, and then there are some other side effects like dizziness and nausea and headache. And the whole problem with dantrolene, every time people talk about the stigma of, it's caused liver toxicity. And I just want to clarify a few things here
please.
About liver toxicity, because people may not be aware of where this is coming from. So FDA has a red flag or warning about liver toxicity from oral dantrolene. And it comes back, or it goes back to 1970s, of a paper that showed 3 people died of liver toxicity while they were on dantrolene. Those 3 people, they had some other liver disease and were on medication that also caused liver toxicity. Then post-marketing, data showed about like the mortality from liver toxicity. Patients were on dantrolene was 0.00009%, which is relatively good. Then if you go back and get the data, which I did, people who died, they were on over 400 milligram dantrolene per day. Again, there had been some other issues. Maybe they were on other liver toxic drugs, or they had other comorbidities. As well as the mean dose was actually 580 milligrams, which is quite high. Most of our patients, if you look at our paper, they are between 25, yes, the range is 25 to 400 milligram, but most of our patients, more than 80% of our patients, they are on under 200 milligram dantrolene. As I said, it helps with their muscle pain. Some people have regain their functional abilities, their even daily activities that they were not able to do it. They are now able to do it and enjoy their life. So, and full disclosure, I'm not getting paid by dantrolene, any of the dantrolene companies, and I have done one consulting, or I have received one consulting fee from Norgine maybe 10 years ago, which they make the IV dantrolene and not oral, so I have to say that.
Nicole?
Well, what we have seen, a few Dutch patients use it, and usually in a low dose, so once or twice a day, 25 milligram, with a reduction of myalgia and cramps. And there's one young person who has used it now for over 15 years, and she presented as a teenager with recurrent episodes of rhabdomyolysis, and with a low dose of dantrolene, she's never hospitalized again. She has had some episodes, but not higher than 10,000. And she feels it very well. Whenever cramps come up, she uses a second tablet, and otherwise it's only once a day, 25 milligrams, and that functions very well for her. So reduction of severity of rhabdomyolysis is another reason why you could prescribe it.
Do you have it?
Yeah, very similar. I follow Sheila and Nicole's paper. I have a few patients on dantrolene, all of them with the malignant hyperthermia sensitivity mutations, variants, and appropriate phenotype associated with that. So rhabdo or the cramps, and it does seem to provide some benefit. We follow it closely in terms of their symptoms and work up the dose until they kind of want to not increase it, and then check the liver enzymes, once every few months.
So just a quick follow-up, and then I want to move on to the next topic. But every now and again, we get a call or an email from a patient saying that they think they would benefit from dantrolene, but they cannot find a doctor, at least in the United States, who's willing to prescribe it. That anesthesiologists feel comfortable with it, but of course most anesthesiologists are not seeing patients in clinic. Any thoughts on that? Are your neuromuscular specialists, are most of your colleagues in that field comfortable prescribing dantrolene, or is this a rare thing, or how difficult is it for patients to access oral dantrolene?
I think it's an individual choice since the drug is not approved for this indication. I think any physician sort of has to decide whether they want to decide to prescribe it or not. I'm happy to interface with any of the doctors that you're talking, if they want to talk to a neuromuscular physician that has prescribed it here. I'm happy to do that.
And Sheila's paper is really helpful because it is it's not a prospective study, but it contains data of a large series of patients, and that is most likely going to support a neuromuscular neurologist to do this and try it.
I mean, would the FDA, would there be any move to sort of make it an indication that the FDA, is that, no?
Well, we're working on it, but it's a long way.
Okay.
But I just had one comment. I'm also a neuromuscular neurologist for other disease, and I see a lot of people who come to my clinic with cramps, and cramps have many different causes also. And if you have a malignant hyperthermia susceptibility, it doesn't mean that other causes cannot contribute to cramps. So it's also good to see, do you have other medications which have muscle cramps as a side effect, such as statins, but also others? Are you using a lot of caffeine, because that causes cramps in any individual? So it's always good to keep having common sense about this topic. It's not only malignant hyperthermia
Perfect.
Susceptibility causing cramps.
All right, we're short on time, so 2 topics. Yeah, Bob.
Question: if you take dantrolene all together at nighttime, is the half-life long enough that you still get enough of that drug around by the next evening?
So higher dose actually increases the duration of effect. That is true, but it also depends on your metabolism as well. And that's why if you don't, I always tell patients, you have to see if there is an effect in the morning or not. If there's no effect, you increase the nightly dose until you get the effect. Now, if you get the effect and say by 2 p.m., 4 p.m., you lose it, you're basically metabolizing the drug, so you have to get the second dose. But based on the half-life only, if you look at it, I mean, outside of, as just a pharmacological basis, you have to take it every 6 hours to get the effect. But in the actual body, you can get away with the dose and your metabolism. Or
So
your
the people
metabolic
who
rate.
get benefit just once a day or at nighttime, are they slow metabolizers then?
Not necessarily slow metabolizer, but yeah, basically it circulates in your system for a longer time. Yeah.
All right, any other questions on dantrolene? Oh, yeah, Dan. Yeah.
Yeah, so I know Dr. Riazi and I were speaking about this. I had many questions, and you were saying that the youngest child that you've administered has been 14. I was wondering for the other doctors in the room what the youngest age has been that it's been prescribed for. Has there been precedent for 6, 7-year-olds?
So I'm an adult neurologist. I don't see young children.
Me neither. And the young person I just referred to, she started on it when she was 15 or 16, but not earlier. And Sheila made a comment about the weight.
Weight. I think, Dan, weight is the problem. And 25 might be too much for a 6 years old, yeah.
But we learned that Cody breaks open the capsules and takes some of the granules in there.
Yes, and I have another patient here who does the same thing because she feels that 25 is too much and she takes much lower dose too. So maybe you can learn from them.
All right. I want to wrap up with two quick, well, we'll try and keep them quick. RYCAL. So if you look on this schematic, we have RYCALs acting at the level of the ryanodine receptor. Is there anyone on the stage who has some familiarity with RYCALs who would like to? No, I'm joking. Dr. Mohassel was the principal investigator for the RYCAL trial. So there are a few people who are as familiar with RYCALs as Dr. Mohassel. And so, Dr. Mohassel, can you maybe just quickly just review the mechanism of action? I know it was briefly discussed at various times at this meeting, but the mechanism of action, and I know you're not affiliated with the company, you're not a part of that program anymore, but your understanding of where we are in the RYCAL program.
So, so the way that drug is supposed to work is it binds onto the RYR1 channel, and it stabilizes its interaction with this other protein, FKBP12 or calstabin, and that sort of reduces the calcium leaks. That's in a nutshell. Now, it seems to actually bind where dantrolene binds the channel, based on some follow-up studies. So now the drug was developed so that it can be taken in a once-a-day dosing by the company, and we tested that in a phase 1 trial just to look at safety and tolerability, so to make sure it's not causing major side effects and it's not annoying to take. You know, it's not giving you even little side effects that prevents people from wanting to take it on a daily basis. And that trial was published last year. So I'll refer you to the details there. We essentially didn't have any, alarming signals in that trial. So the company, I think, is planning to launch a phase 2 trial to see whether, if you give individuals with RYR1 and dominant mutations, whether that is going to help with the symptoms. And that is in the planning stages, but they gave a timeline yesterday of potentially launching in Europe and then subsequently in the United States in early 2026.
And I think, Dr. Bermans, you're involved in the European part of this?
Yes, but how this works is that you then sign a confidentiality agreement.
Okay, understood.
But I've only seen a synopsis, 2-page summary of the protocol, and concerning the timeline, I know the same as what Payam was presenting here yesterday.
Yep. Mother.
If someone in this room wanted to go and take RYCAL on their own, could they go to their doctor and have the doctor write a prescription for a RYCAL drug and get it at the drugstore?
It is not available. It's a study drug. So in contrast to salbutamol or albuterol, which you can get on prescription in the United States and Europe, and in Brazil without prescription, very cheap, I just learned. This is not available, so you just have to wait for the trial, see what comes out, and if it is positive in the phase 2, after that there will most likely be a phase 3 trial.
Yep. All right, Marcy has a question.
So I know that RYCALs initially are for the leaky calcium model, and you mentioned dominant. Does that mean you're looking at the blocked calcium RYR1, or is it RYCAL shown that it will not work at all with a blocked calcium channel?
So again, I'm not designing that, and I'm not involved in writing the protocol for the phase 2, but from what I understand and what's out there, I don't think it makes a lot of sense to treat someone with a blocking mutation with this medication based on what we understand how it works, but it would be more helpful for individuals with the leaky channel mutations, including some of the MHS variants.
Yeah, I mean, it's a great question, Marcy, and we heard from the chief medical officer of Karma at the workshop, and they're very much actively trying to figure out what subset of ROR1 patients, I mean, they're going to look at dominant, but within that realm of dominant, what are the patients that are most likely to benefit? Obviously, those are the patients they want to include. They don't want to include patients that won't benefit because then that confounds the data, right? And so trying to understand, looking at someone's their genetic results, trying to understand, is this a leaky channel, is it not? But in theory, as Dr. Mahasel said, you'd want to include people with leaky channels. So on the last topic, we have, Dr.
It's
Vermans.
not only diluting the data, but it's also asking effort of patients who won't benefit from it. So it's also from the patient perspective
sure.
very good to be very selective.
Yeah, I do want to emphasize that quickly, that when we talk about clinical trials, these are not treatments. These are test compounds, and you're essentially volunteering to see whether that works or not, which is very different from when you go to your doctor. Sometimes it's the same person who is prescribing you a medication to take to see if it improves your health.
So the last thing I want to address just briefly, because we're over time, we heard from Irene about this natural history study. Can you talk about the importance of a natural history study in general, or specifically for ROR1 and clinical trial readiness, and why patients might want to consider being a part of a natural history study?
Yeah, a natural history study is a detailed description of the natural course of a disease, and you want to know how muscle strength, muscle cramps, myalgia, fatigue, and all kind of functional abilities is stable or changing over time. And that's the knowledge you need to know to see if a study drug has any effect. So it's very necessary information before you can start a clinical trial on any kind of drug. And in the workshop, and I mentioned it this morning, I had a Dutch patient telling about his experiences in the NAC trial and also in the natural history studies in Europe, and he also said that it benefited him because it gave him more insight and more knowledge. And that's a benefit. It's not a treatment benefit, but it's a knowledge benefit I think you will have if you participate in a trial. And it's very important to realize a trial is not a medical treatment. So the main motivation should be that you're going to contribute to science, to the knowledge about your condition, and that in the end you might benefit from it, but most likely the next generation will benefit from it.
Anything you want to add?
Yes, we actually discussed this during the research workshop, that natural history studies, especially on RYR1 related disorder patients, would really help us to understanding what functional outcomes are the best to choose for clinical trials, what means meaningful or significant from patients' perspective, and what should we be aiming at. So basically validating our functional outcomes are depending on these type of studies.
Any questions about going to NIH? Like I said, Dr. Mahasel was the principal investigator on the one of two ROR1 trials at NIH. So if you have any questions about what it's like to be there or what it entails, this would be a good opportunity. If there are no questions, thank you very much to our panel, Dr. Mahasel, Vermans, and Riazi.